Okay, I'll talk about coagulation, heparin, warfarin, and something on hemophilia, and then maybe like 1 point on hepatocellular carcinoma. Now, your normal blood vessel, when it's intact without any damage to its endothelium, which is its innermost layer, usually it has an anticoagulant phenotype. So all your clotting factors which are released by the liver, they flow freely in the blood. You will only form a clot in a place where there is damage to your vessel's endothelium. Because normally your vessel and the things that are there outside the vessel, your blood with your clotting factors is inside the vessels. And after the damage to the endothelium, stuff present outside the vessel will be exposed, which will then activate your clotting. So normally your vessel has an anticoagulate phenotype. Now, after there was an injury to the endothelium, there will be exposure of subendothelial matrix. Below the endothelium, whatever is there, it will be exposed to the blood. Now, you will have platelets which are flowing in the blood. Your kahani, your story starts with the platelet. The collagen in the subendothelial matrix and the von Willebrand factor will bind to glycoprotein receptors present on the surface of your platelets. Collagen binds to 1A, von Willebrand factor binds to 1B. This will cause adherence of the platelet to your subendothelial whatever. This will cause platelet adherence and activation after binding to these two. Upon activation, there will be two things. One, you have here glycoprotein 1 receptor function done. Glycoprotein 2 receptor 2B or 3A. There will be a conformational change. This I will talk about later. First, let's just put this aside. Upon activation, there will be release of thromboxane A2 newly synthesized. There will be release of ADP, there will be release of serotonin from inside the platelet outside into your local space. The thromboxane will cause vasoconstriction. The ADP will cause aggregation of platelets. The serotonin will cause both of the above functions. The thromboxane A2 will also cause further activation of the platelets, releasing to further release of these three. More vasoconstriction, more aggregation. So all your platelets are now close to each other because of the vasoconstriction also and because of them adhering also. Now, the conformational change in the glycoprotein 2B3A integrin will cause binding of fibrinogen. Fibrinogen was also produced in the liver. It is freely flowing in the blood. Only when, because of injury, your platelets, the receptor on the platelet will change only after the injury. This changed integrin GP2B3A will bind to fibrinogen, which was there in the blood free flowing. Now, this binds the fibrinogen. Now, there will be many activated platelets, as I just told. Now, imagine there is one platelet, there is another platelet. This platelet will bind fibrinogen. This platelet will also bind the same fibrinogen. What is this called? Cross-linking. Those both have linked through something else. So this will cause cross-linking of adjacent platelets. This will cause the formation of a platelet plug. This sentence I will talk about later, or maybe not. At each step, a clotting factor zymogen undergoes limited proteolysis, not full proteolysis, otherwise it will go away. Limited proteolysis and becomes an active protease. Your clotting factor will also be called protease in some books. If you are reading a book, which you will obviously have to after watching this video, you will maybe get confused, so don't. Now, let's go to the coagulation cascade. There are actually two defined clottings. One is in vivo, one is in vitro. In vitro is in the lab. You have intrinsic factor and extrinsic factor. Intrinsic pathway and extrinsic pathway. The intrinsic pathway in the lab will give you your APTT, value. Extrinsic will give you prothrombin time INR value. That is defined in the lab, not seen in the body. But in the lab, when you take the blood and add whatever things you add, you will get all the clotting factors information, not just the ones that we will discuss in the body, because drug you will give in the body, not in the lab. Now, your tissue factor. Tissue, there is a factor in the your tissue is there. This breaks. The tissue factor will be exposed. So your tissue factor is exposed now. This exposed tissue factor will activate factor 7. All these are zymogens. These are proenzymes. These are proteases which are inactive, freely flowing in the blood. So nothing will happen. They are not active. Once you are exposed tissue factor after endothelial injury is there, some cut you got, something happened in the body, some microbe, whatever, then only these will get activated. Okay, tissue factor activates factor 7. Your story is starting with factor 7. It will activate and then tissue factor will bind with the factor 7. Now this complex will mainly activate factor 10. Now factor 10 will bind to activated factor 5A, which was activated in some other scenario. We will talk about that later. This 10A will bind to 5A. This 10A 5A complex is called the prothrombinase. Prothrombinase factor 2. A's will break factor 2 or activate factor 2 to factor 2A. Factor 2A is also called a thrombin. Thrombin is your main culprit, main hero of your story is thrombin. Many functions you will get. You open Robbins, you open Goodman Gilman, you open Kaizen, you will get to know. You open Guyton, you open Gana. Thrombin is your main thing. Factor 2A is also called thrombin. This thrombin, it will have many functions. Some of the functions which I will talk about is your direct activation or direct leaving of fibrinogen to fibrin. This fibrinogen is insoluble. Insoluble. Fibrin is soluble. Now, this fibrin will imagine a full protein having many corners, many sides, many free things. Now, for the protein to stabilize, for all the fibrin to very nicely stabilize and come together, there is another factor called factor 13, which is also activated by 2A. This 13 is a transaminase which will stabilize the fibrin. Now, this fibrin can become a clot. So, where were we? Your platelets, they cross-linked, they formed a plug, or from the free-flowing blood, everything is coming and then sequentially getting deposited. When it is getting deposited around the platelets, so all of this is happening. Fibrin is coming and getting deposited here. There's a very good diagram in Robbins. You can go and see after this video. Now, all these disturbances, black lines I have drawn, these are important. Your 2A, instead of apart from directly doing this fibrin cast story, it will also upstream activate your 5A, 8A, 9A, all of this it will activate. This amplification is very important. Why? I will tell you. You know hemophilia A and B. A is factor 8, B is factor 9. Now, if you see in the till fibrin from tissue factor, if you draw this one line, 7 you will get 10, you will get 5, you will get 2, you will get directly. Will you get 8 or 9? It's not there, no. This is there on the sides, they will activate also. This 2A is going and activating your 5, 8, 9. Now, why is it this amplification is important? Imagine a vessel, endothelium was damaged. All of these clotting factors have now activated. Very small clot you will get. One very small platelet plug, one very small amount of fibrin clot forming. Then how will you get a big clot and full closure of the endothelial damage? Through this upstream feedback amplification of 5, 8, and 9. This is important. This is why hemophilia A and B are so bad. You will get your small platelet plugs you will get. Will you get big proper platelet clots? If you get hit by a ball, for example, obviously some endothelium will damage, no, on your arm or on your trunk, wherever you get hit by the ball. Now, will you bleed through that? No, your body will very easily form clots over there. But will hemophiliacs be able to have this amplification of actual proper clot formation? This is important. You should not say, ki, we will not discuss about this. It is to be discussed. That's why hemophiliacs A and B, the hemophilia is so bad. That is why we call it disease. Now, more discussion is required here in this diagram. You can see the color coding here. It will not be carried forward just for this page only, yellow and green. In yellow, you will have in now your body cannot you got bruised, for example. All of these clotting factors getting activated will cause ransom elsewhere in the body also, no. Too many clots you will have. So physiologically, you see some anticoagulation, anti-clotting factors are also there. In if required, clotting will activate. Simultaneously, anti-clotting will also activate. You will have a lot of things, plasminogen activator, TPA, this, that, all are there. But here we will talk about specific things only. So this factor 2, factor 10, factor 9, once activated, after they are used, they will be cleaved by antithrombin. These are all endogenous physiological things I'm talking about. And factor 8 and factor 5 will be inactivated by protein C and protein S. This I will talk about later or not. Maybe okay, let me talk about it right now only. Factor 5 latent mutation. If the mutation is there, factor 5 is mutated. Now it is inactivated by what? Your protein C, protein S. Now, after the mutation, it cannot be inactivated. So, too much activated 5 you will get, too much clotting you will get. This one thing you can know. So now we will talk about some lab things. If you want, you can read a hematology textbook. You can look at Google also for proper definition of your APTT and PT. Here, I just want to, as I said before, they are defined in the clotting that happens in the lab in vitro, not in vivo. In vivo, whatever clotting happens, there only some specific factors I will talk about. For example, your factor 8 and factor 9 are from what pathway? The intrinsic pathway. Intrinsic pathway, extrinsic pathway. Both have from starting from 10, 5 to they are all common to both extrinsic and intrinsic. What is exclusive difference between APT, TPT, intrinsic, extrinsic? You have factor 9, factor 8, and this is for intrinsic, which we measure in APTT. In PT or INR, we measure your factor 7, which was from extrinsic pathway. So this also you remember, this I will talk about later in heparin and warfarin. Now we will come to mechanism of action of heparin. Now heparin, there are two forms. You have unfractionated heparin or you fractionate the heparin and you get the low molecular weight heparin out. Example is enoxaparin. Now I will tell the mechanism of action. Your antithrombin was there above, antithrombin, which was physiological already present. Now in your body, clotting is happening due to some reason, damage, disease, physiological, pathological. Clotting is happening. Now the antithrombin will try to stop the clotting. Your heparin will catalyze, it will make the antithrombin better. How? It will help the antithrombin to bind to your 2, 9, 10, whatever things better, more fastly. By how much? By more than 1,000 times. So, clotting will not happen. All the clots will go away. So, heparin is an anticoagulant. Here you can see the mechanism of action in that entire process. Now, If you can see this 2, 10, and 9, 2, 10, 2, 10, and 9. These two are common to both the lab values. This one is exclusive in the heparin mechanism of action to APTT. So for heparin working, we will check which lab value? APTT. Now let's come to warfarin. This is a bit more complex. Not very complex, but you will have to open your brain a little. Warfarin is not directly affecting anything here. It is not inactivating anything after a clot has formed, for example. When the clot is getting formed, can warfarin do anything? No, it can prevent formation of future clots. I will tell how. But once the clot is at the time, acutely, if your clot is forming, you have some acute hypercoagulable state, you have some DVT or something, your warfarin will not work. Why? Because all these clotting factors are already activated. Your already activated clotting factors, you can inhibit with the help of heparin. But warfarin will stop the synthesis of your clotting factors. So, if acutely some hypercoagulable pathology you have, warfarin can decrease the synthesis of your zymogens. Right now, all these clotting factors are activated. If you give warfarin, will something happen? You have to inactivate those clotting factors. You have to break the clot. Nothing will happen. If the hypercoagulable state, if you have to, manage, then you have to give heparin because only that can inactivate. In the future, after a few days, your warfarin will start working after all the pro-clotting things in your body have gone, metabolized, excreted. Okay, now let's come to mechanism of action of warfarin. Warfarin also does not very directly affect your synthesis of clotting factors. I'm saying very, very directly because very directly you would expect something to happen here, but it is happening in another cycle. This will be important because you can give some forms of vitamin K to help with warfarin toxicity. That's why you can give vitamin K. Now, this step here is blocked by warfarin. This step here was helping this step here to form the prothrombin. Now, if someone asks a very, very, very specific chemistry type question, if they are very, you know, trying to mess with you, they will ask about this descarboxyprothrombin. Now, the exact definition which you will get or the exact mechanism of action you will get from Katzan, they will say your coumarin anticoagulants, warfarin is one of them. It blocks the gamma carboxylation of the glutamate residues of all these clotting factors and things related in the clotting cascade. Now, you will say ki, array, your carboxy is there. It is supposed to, here decarboxylation is happening. But what is it blocking? Carboxylation it is blocking. Then how? Descarboxy means no carboxy. Because in the prothrombin, normally you have two carboxys. Here you only have one. So this is less carboxy, descarboxy. So it is not blocking decarboxylation, it is blocking carboxylation. It is blocking gamma carboxylation of glutamate residues. These glutamate residues you can see in the diagram. Or whatever. Okay. Now factor 2 was there. Similarly, it also does the same for factor 7, factor 9, and factor 10. But now a very big twist you will get. It will also inactivate biologically. Now, these things that are formed, these are if you block this step, the things that will be formed here, these accumulations, blah blah, these will be prothrombin only, but they will be obviously very biologically inactive. No, it will deplete. No, it so that is anticoagulant activity very good, but it will also deactivate protein C and protein S. The balance that you had of true and anticoagulant, it will obviously push it towards the anticoagulant only. But it will also cleave protein C and protein S. Why do we care if you are saying that ultimately it is pushing to anticoagulant only? This is clinically important. I will talk about later why. Come to this paragraph. If you can pause and read, please pause and read. I will skip a little. Now imagine the body. It has all the inactive circulating zymogens in your blood. You gave warfarin. Now there is no more synthesis. All the things that were circulating are still circulating. They are things, they will be cleared by the liver, by the reticular endothelial system. Somehow they will be cleared. It takes time. What are the time? What are the half-lives? For factor 7, the half-life is 6 hours. Now, protein C also it will degrade. Protein C was anticoagulative. If you degrade anticoagulative protein C, you will get a procoagulant state transiently. It is paradoxical if you have read the paragraph. Now, this protein C has a lesser T half than your factor 7. The first thing to go away if you give warfarin is factor 7. But factor 7 is also very important. It is in your body, extrinsic pathway, it is there, no? So, if protein C is going away before factor 7, before all the procoagulants go away, anticoagulant is going away. So, if the anticoagulant protein C goes away first, you will have a short procoagulant period. Once factor 7, then 9, then 10, then 2 are depleted, then you will have anticoagulant, obviously. So, this initial procoagulant state is there in warfarin use. For this reason, in patients with active hypercoagulable states, such as acute DVT or pulmonary embolism, unfractionated heparin or low molecular weight heparin is always used to achieve immediate anticoagulation because it will inactivate whatever clotting is going on right now until adequate warfarin induced depletion of procoagulant clotting factors is achieved. This duration of the overlapping therapy, both are given as 5 to 7 days. So, this is an important thing that you have to remember. This also you can read it is the same thing only. So, first your factor 7 is going away. Now, if you want to check the test, first factor 7 is going away. After you know that, you have read in the paragraph. This paragraph is from Kaizen. Now, say you want to do testing to see what warfarin is doing in the blood. Is it working or not? These are the things that it is affecting. Warfarin is affecting all this. First, it is affecting this. What is this factor 7? If you go to this page, factor 7 was seen where in prothrombin time. So, warfarin, you have to check prothrombin time or INR. If you want to see the definitions of prothrombin time and INR, you can go and consult a hematology textbook. Now, protein C was degrading 5 and 8. You can check that. Obviously, we have already discussed that.